Great, thank you so much. The other topic I was asked to address is colon polyps. What is their natural history and how should we look for them and how should we deal with them in our practice? So this is what we know. We think the earliest changes are these really small adenomas that over time acquire dysplastic changes and become more advanced and then eventually turn into carcinoma. So truly the key to prevention is to detect them at the earliest possible stages and recognize them, remove them completely to prevent colon cancer. How effective is polipectomy if we do that sequence? Well, we used a very large study with 46,000 individuals that had undergone screening versus controls. And we used an instrumental variable approach, which essentially makes these groups equivalent by using randomization as an instrumental variable. So we found that the reduction in colon cancer incidence is almost 70% by polipectomy. And when we looked at just polipectomy of adenomas, we can expect to reduce the incidence of colon cancer by over 70%, which is why what we do is so important every day. So here are some principles of polipectomy. Extremely small polyps can be removed using forceps, and these should be cold forceps anywhere in the colon. Diminutive polyps, which are 5 millimeters or smaller, can be removed by cold forceps, but we are now advocating the use of cold snare polipectomy in case there's any residual tissue left. Small polyps between 6 and 9 millimeters are best removed by cold snare, hot snare, or endoscopic mucosal resection techniques. And larger polyps should really be, we should be using either hot snare or EMR. We should aim for en bloc resection, and submucosal dissection is an option for larger sessile polyps, larger than 2 centimeters. And I've provided you 2 references to the Multi-Society Task Force guidelines. I'm a member of them, and we've outlined a lot of these in detail there. So this is what polipectomy technique might look like. It's essentially recognizing the polyp, having good prep to be able to do so, and then using the best possible tool. Most of us will be using cold snares and completely removing the polyp. I also wanted to talk about malignant polyps, which we've addressed in our guideline, and it's a field that we should really be thinking about and looking for. So we find polyps 10 to 60% of the time in our colonoscopy. We find cancer or these malignant polyps about 0.2 to 5% of the time we do colonoscopy. And the term malignant means that they've gone past the mucosa into the submucosa. And these truly are polyps that we can now remove endoscopically. So just to give you a picture of what that looks like, most polyps we deal with, these advanced adenomas, are limited to the mucosa. Once they go into the submucosa, they are technically a T1, a PT1 cancers. However, if they're in the superficial submucosa or even in the deep submucosa, we as endoscopists can detect them and remove them. So step 1 is endoscopic recognition. Looking at a polyp and then deciding, is this a polyp that is a malignant polyp that is limited to the submucosa, and should I attempt to remove it? So this is where endoscopic assessment comes in, looking for features associated with deep submucosal invasion. And I'll go over some of the classification systems that we use. The one that's used across the world, it's called the NICE classification. It breaks down polyps into type 1, 2, and 3. And it's truly these type 3 polyps with deep submucosal invasion that we may want to avoid. And again, these are easily identified by use of higher magnification and putting on narrowband imaging in some cases. The second thing to look for are the kudos pit pattern. And the idea, again, is to either use dye, or this can be done just with high magnification without dye, but start looking at some of these things. Look at the pit pattern on the polyp very, very up close. Does it look like it has small, round, normal-looking pits, or do they start looking like they're branched or they look dendritic? And then finally, we see these irregular pit patterns. which are truly where we worry about that this may be a malignant polyp with deep submucosal invasion. The Paris classification is also widely used, and we now recognize polyps can be polypoid, they can be non-polypoid or flat, or they can even be excavated. So it's important to understand and recognize them and look for them in endoscopic practice. And below, I've given examples of how each of these look like during endoscopy. So it's very important to, one, recognize them. Second, understand which are the ones we truly worry about, such as, the depressed ones where we truly think there might be underlying deep submucosal invasion. And then finally, a new terminology in the literature are called laterally spreading tumors. These are sessile tumors that spread laterally instead of growing vertically. And the classification was proposed for polyps larger than 10 millimeters that are either sessile or flat and laterally spreading. So they belong to two categories, either granular or non-granular. And within those types, you can see that there's subclassifications of granular homogeneous, granular mixed, non-granular flat, and non-granular pseudo-depressed. Also, you can see the risk of malignancy associated with those four categories. So it's important to really look for the non-granular as well, particularly with features of pseudo-depressed. And those may be ones that we don't want to try to remove endoscopically, tattoo proximal the area and send them to a surgeon. So what they look like in practice are as follows. The first example is laterally spreading granular homogeneous. The second one is a granular mixed. The third one is a non-granular flat elevated. And the last one is that one with a pseudo depression that we definitely want to avoid, likely has deep submucosal invasion. The next thing is the depth of submucosal invasion. And truly the cutoff is about 1 millimeters or 1,000 microns. And that's where the risk of having lymph node or vascular metastasis increases, where endoscopic resection alone is not enough. And these are individuals we should be thinking of sending to surgeons. The exception is pedunculated polyps. Pedunculated polyps with deep submucosal invasion, we can remove and block endoscopically, and they don't have distant spread. So the other common scenario is you take out a polyp and now the pathology comes back as being a malignant polyp. What do you do in those cases? And the question is which ones you decide to send to the surgeon and which ones you just bring back for polyp surveillance. So non-pedunculated polyps, if the pathology, and talk to your pathologist about these features. If they have poor tumor differentiation, they have lymphovascular invasion, the submucosal invasion depth is more than 1 millimeter, or the cautery margin, the tumor involves the cautery margin, or there's tumor budding. Those are high risk for lymph node or distant mets and should be sent to a surgeon. Pedunculated polyps, even when they have poor tumor differentiation, lymphovascular invasion, or the tumor margin is within 1 millimeter of resection, are also at high risk of having distant spread. So again, highlighting the importance of complete polipectomy. And I don't expect you to look at this, but I've given you a reference. This is the approach to polipectomy. And again, you can go through this and kind of go through the branch points and decide what should be done next for these larger and worrisome polyps. But it truly is a multidisciplinary team approach. The team members are the surgeons, the pathologist, and the oncologist. But you as GI are the captain of the ship, because the patient is your patient. You get to decide which direction it should take, taking into account the patient's values, preferences, their age, comorbidities, life expectancy, and come up with a shared decision about what should be done next for these malignant polyps. And truly the goal is to prevent over or under utilization of surgery. So next I'll turn to some surveillance examples, and we'll look at some of the latest guidelines. So in this first case is a 60-year-old male presented for routine follow-up colonoscopy. His last colonoscopy was 3 years ago. And so you look up the report in your system and that's what it shows. Looks like there was one polyp, which was smaller than 10 millimeters. The prep was good, exam was complete, and the polyp was a tubular adenoma. And he's worried about his risk of cancer. And he asks, should I get a colonoscopy now? It's been 3 years. So what would you do? Reassure him that he's good for another 4 to 7 years, which would be 10 years from his previous exam. Order a colonoscopy now because he's worried. Order a fit test, or say we'll talk about this in 1 year. So I want you to think about this as I go through the guidelines. So this is another document that we produced from the US Multi-Society Task Force, and these are recommendations to follow up after polipectomy. So the terms I'm going to use: low-risk adenomas are adenomas that are 1 to 2, they're tubular, and they're smaller than 10 millimeters. Advanced adenomas are large. They may have villous features or high-grade dysplasia. And advanced neoplasia is advanced adenomas plus cancers. Sessile serrated adenomas or polyps are histologically confirmed. So let's go through some of these definitions. The main change in our guidelines was in these two categories, the low-risk non-advanced adenomas. I also wanted to highlight the British Society guidelines, which have slightly different definitions, but again, they define high-risk features as more than 2 polyps larger than 1 centimeter or more than 5 premalignant polyps. So the US Multi-Society Task Force recommends screening in 7 to 10 years for these 1 to 2 small tubular adenomas. The reason for that is we have now great evidence that their risk is no higher than people without any findings on colonoscopy. And I'll walk you through some of these studies. This was the first meta-analysis of 8 studies with 10,000 individuals. They compared the outcomes of people with no adenoma, low-risk adenomas, or advanced. And you can see the low-risk adenoma, the risk of having advanced neoplasia at 5 years was very similar to people with no adenomas. In the next study on the top, they also looked at colon cancer incidence in people with low-risk adenomas compared to no findings or high-risk adenomas. And again, you can see in the top graph, the blue and the orange lines are vertically overlapping, suggesting their long-term risk of colon cancer is very similar to people without any polyps. The group that truly separates out are those with high-risk adenomas. Not only that, their risk of fatal colon cancers is same as the general population or even lower. So these data gave us confidence to tell individuals that they can have a colonoscopy repeated in 10 years, similar to people with no adenomas. And then this is yet another study, risk with 1 to 2 adenomas. And you can see that's very similar to risk with individuals with no polyps. So these are what the recommendations look like. It starts with a high quality colonoscopy, which is complete to the cecum, good bowel prep, good adenoma detection rate, and complete polyp resection, all the things we talked about. Then we can stratify people into these buckets. If 10 years, if they have a normal colonoscopy or small hyperplastic polyps, 7 to 10 years for 1 to 2 small tubular adenomas, 5 to 10 years for 1 to 2 sessile serrated polyps, 3 to 5 years for 3 or 4 adenomas that are small, and 3 years when the adenomas are more than 5 or advanced or large or have high-grade dysplasia. So the question is, why use a range, right? Why say 7 to 10? Why not pick 7 or 8 or 9 or 10? Because it's potentially confusing. Is it 7? Is it 8? Is it 9? And then if you say 7 to 10, most people will use 7 because they're not comfortable going 10 years. The response is that the range is truly reflective of the evidence we have now, and it truly allows clinicians to make decisions with the patient. So maybe if it's a low-risk patient and they have high comorbidity burden and other things, I would give them a 10-year pass. But for somebody else, I may give them a 7. So it gives us some more opportunity to make shared decisions. And we can then use it to our advantage. So again, truly the big change in the guidelines is 1 to 2 tubular adenomas is now 7 to 10, and 3 to 4 tubular adenomas is 3 to 5 years. We used to bring them every 3 years. Now we can go up to 5 years. Again, contrasting it with the British Society guidelines, they tend to be a little more stringent. And for them, high risk findings would mean that they come in 3 years, and high risk findings are 2 polyps with more than 1 advanced or more than 5 malignant polyps. So similar, but a little more conservative. Not only the first interval, we've actually given recommendations for when the second interval should be. So say somebody has 1 to 2 small tubular adenomas, and we bring them back in 7 to 10 years, and now that colonoscopy is completely normal, we will give them a 10-year pass. Similarly, somebody that had, say, 3 to 4 tubular adenomas, we brought them back at 3 years, and now they have a normal colonoscopy, will go 10 years. So no more is it, automatic every 3 years or every 5 years. We actually lengthen intervals based on the last exam. So that's important to know also. And again, the British Society guidelines by age also say if there's a high risk criteria colonoscopy at 3 years, and then they actually turn them back to average risk screening if there's no findings. So they're a lot more conservative. So going back to that case, the 60-year-old who was worried about his follow-up, based on the guidelines, we would reassure him and say that he's not due for another 4 to 7 years, which would be 7 to 10 years from his previous exam. So a second case, a 56-year-old female undergoes colonoscopy for abdominal pain. There's a sessile polyp in the ascending colon. And you can see the sessile polyp. These tend to be, very subtle, difficult to see. They often have a mucus gap, but the borders are irregular and it has a cloud burst like appearance. So again, very challenging to detect, often seen on the right side where PrEP can be challenging also. And the histology is a sessile serrated lesion. What is the best recommendation for her for a follow-up exam? Is it 1 year, 3 years, 5 to 10, or no further surveillance? So let's look at these serrated polyps. Again, there's very little data because these are a relatively recent entity that we're just developing evidence on. But the available data suggests that having a sessile serrated increases your risk of future serrated polyps. And there's an increased risk for high risk adenomas in people with an SSP and a tubular adenoma. So are they truly as bad as we think they are? So this is a study that compared individuals with no polyps with serrated polyps based on size and number. And you can see the risk of colon cancer at 5 years and 10 years truly goes up when they're large serrated polyps or serrated polyps with an advanced adenoma. But otherwise, the smaller ones seem to behave very similar to tubular adenomas. So our guideline also has recommendations on serrated polyps. And again, this graph kind of highlights what we should be doing. For smaller sessile serrated polyps, which are 1 to 2 or even 3 to 4, we can go 5 to 10 year intervals. Again, the data are weak, which is why there's such a big interval of 5 to 10 years. The British Society guidelines actually also define sessile serrated polyps that are either large, have traditional serrated adenoma or high-grade dysplasia as being high risk. Otherwise, if they have 1 to 2 small sessile polyps. So going back to that case, the 56-year-old, based on the guidelines, we would give her a 5 to 10 year interval pass for her next surveillance colonoscopy. So in summary, surveillance colonoscopy is appropriate in individuals that have previous adenomas. That's high value care. New evidence shows that 1 to 2 small adenomas or SSPs have similar outcomes as individuals with normal colonoscopy, and hence we have lengthened the intervals. Surveillance has been extended to 7 to 10 years for 1 to 2 small adenomas. And in the future, we'll probably lengthen intervals even more. And the findings at the first colonoscopy are then followed up with what's found at the next exam, and that should determine the follow-up interval. So no longer are people on an automatic every 3-year plan or every 5-year plan. And in the future, we might actually, as our colonoscopy gets higher quality, we might be comfortable lengthening screening intervals beyond 10 years. So more to come on that. With that, I thank you for your attention.